Hello friends, today our topic of discussion is antenatal hydronephrosis. So in this topic today we will discuss about the monitoring and management of the antenatal hydronephrosis. We will not go in theoretical details, only we will discuss about how to monitor antenatally, how to manage postnatally and how to grade the severity of antenatal hydronephrosis in antenatal period. So first is how to grade the severity of antenatal hydronephrosis in antenatal period. Two grading systems are there. First is the based on the anterior-posterior diameter of the renal pelvis of the fetus. Okay, anterior-posterior diameter of the renal pelvis. Second is the SFU grading, Society of Fetal Urology. So first we will come to the AP diameter. So here, what is the significant when we will call hydronephrosis? So if baby is in fetus in second trimester, so more than 4 mm is the antenatal hydronephrosis. AP diameter of renal pelvis, if it is more than 4 mm, then it is the hydronephrosis. But in third trimester, if it is more than 7 mm, then we call antenatal hydronephrosis. So after that, if we divide in categories, so in second trimester, if AP diameter is 4 to 6 mm, that is mild, moderate is 7 to 10 mm, and severe is more than 10 mm in second trimester. If fetus is in third trimester, then 7 more than 7 mm is significant, 7 to 9 mm is mild hydronephrosis, 10 to 15 mm moderate hydronephrosis, and more than 15 mm is severe hydronephrosis. So this is the classification according to the AP diameter of renal pelvis. Next grading system is the SFU grading system. Here is 4 grades are there. SFU grade 1 is the slightly dilated renal pelvis. Okay. SFU grade 2 is more dilated renal pelvis with dilated major pelvis also. That will be grade 2. SFU grade 3 is significantly dilated renal pelvis with major and minor calyces dilated. Here, major and minor both calyces are dilated, but renal parenchyma is spared. But in SFU grade 4, the renal parenchyma also is involved. After major and minor calyces, renal parenchyma also is involved, and parenchyma thinning is there in SFU grade 4. So these two grading systems are there for assessment of the severity of antenatal hydronephrosis. So now coming to how to monitor antenatally, how frequently we should do antenatal sonography to assess the severity of antenatal hydronephrosis. So first we have to see it is unilateral or bilateral. If it is unilateral, then only we have to do once in third trimester. We have diagnosed in second trimester, so we have to see once in third trimester also is it increasing or decreasing. But if antenatal hydronephrosis is bilateral, so then maybe it can be lower urinary tract obstruction. In that case, we have to monitor the severity for every 4 to 6 weeks. So every month or every 4 to 6 weeks, we have to assess the severity by frequent USG. Or if associated other extrarenal anomalies also are there, then we have to do genetic testing also and genetic counseling also we have to do. Now coming to how to manage postnatally of these babies. So after birth, we have to do USG of these babies. When to do USG? So if hydronephrosis is bilateral or we are suspecting the lower urinary tract obstruction, LUTO, then we have to do USG within 24 to 48 hours. We cannot delay in these cases. We have to do within 48 hours. But if hydronephrosis is unilateral, then we can do at between 3 to 7 days, because we should do USG after diuresis starts. So in newborn babies, diuresis starts after third day. So in that unilateral cases, we should do USG between 3 to 7 days, but in bilateral, we should do within 24 to 48 hours. Now, we have to categorize in 3 categories. First, if APD diameter is less than 7 mm or SFU grading is 0, means there is no hydronephrosis. less than 7 mm is no hydronephrosis. So if antenatally there was hydronephrosis, but postnatally after birth, if APD diameter is less than 7 mm, then there is no hydronephrosis. So in these cases, we should do repeat USC every 3 to 6 monthly. So every 3 to 6 monthly, we should monitor postnatally also these babies also. But if APD diameter is between 7 to 10 mm or SFU grading is 1 to 2, means there is mild hydronephrosis is there postnatally also. In these cases, we should do USC every 3 months to monitor the severity is increasing or decreasing. Third category is if APD diameter is more than 10 mm, it could be more than 15 mm also. So, or SFU grade is 3 to 4. So, here these cases are moderate to severe hydronephrosis. 10 to 15 mm or more than 15 mm or moderate to severe hydronephrosis. So, in these babies, we should start antibiotic prophylaxis. Cephaloxime we can start 10 mg per kg per day, OD dose. Antibiotics prophylaxis we should start because these babies are at high risk of urinary tract infection. And then we should plan MCU, micturating cystourethrophy of these babies. When to do MCU of these babies? So if we are suspecting the lower urinary tract obstruction, means bilateral hydronephrosis there, then we should do MCU within 48 hours. In Luto cases, we should do within 48 hours. But if it is unilateral, then we can plan MCU at 4 to 6 weeks. So after MCU, how to manage? So after MCU, if MCU is suggestive of lower urinary tract obstruction, maybe in male babies would be posterior urethral wall. So in these cases, we have to do immediate surgery. We have to resect the walls cystoscopically. So this is the case. If in MCU suggestive of VUR, vesico-ureteral reflux, in these cases we have to start antibiotic prophylaxis and we have to manage conservatively only. And later on, if needs, then we have to do ureteric implantation, reimplantation. But if MCU is normal, MCU is completely normal, then we have to plan radionuclear scanning of kidneys, that is called renogram, at 4 to 6 weeks of age. So if in renogram it's suggestive of the obstruction like pelvic-ureteric junction obstruction, PUJ obstruction, or uretrovesical junction obstruction, then we have to see that how is the differential function of the kidneys in renogram. So if differential function of the kidneys is more than 45%, then we have to manage conservatively. If differential function is the less than 45%, means kidney is compromising, kidney functions are deteriorating. In these cases, we have to do surgery. Okay, differential functions we have to see. But in renogram, if there was no obstruction, then we have to repeat USG every 3 to 6 months to look for this dilatation or severity of hydronephrosis. So in antibiotic prophylaxis, what should we give? So generally we use cephaloxime 10 mg per kg per day in OD dose, or we can give amoxiclav also. Amoxiclav also we can give in OD dose, or sometimes we give cotrimoxazole also. So cephaloxime, amoxiclav, or cotrimoxazole we can start for antibiotic prophylaxis. And in renogram, radionuclear scan, which scan we should do? So technetium MAC3 scan or technetium EC scan. MAC3 or EC scan we should do. In this we have to see that the excretion of this radioactive tracer. So if there is no obstruction, there will be, in that case will be peak and there will be certain excretion will be there. But if there is obstruction is there, then there will be like late peak will be there, then plateau will be there. So it means there is obstruction is there. So this is about renogram and antibiotic prophylaxis. So this we have discussed about how to manage antenatal hydronephrosis antenatally and postnatally. Thank you so much.